So the dermatologists are typically the people who first see the patient. You've now talked to or had a talk from a dermatologist, but in fact, most melanoma is cured by surgeons. And the surgery of melanoma has truly been revolutionized in the last 15, 20 years. And since there's no one who knows more about the surgery of melanoma than Dr. Edington, he will follow and speak next. Welcome, Howard.
Good morning. There's sort of a running joke in medicine that the medical doctors know everything and do nothing. The surgeons know nothing and do everything. The pathologists know everything and do everything, but it's too late. And so with that in mind, I'm going to take the know nothing but do everything approach. And as I walked in today, it occurred to me that this was probably not the forum to show an X-ray of Homer Simpson's head. However, I will be. So when you see that X-ray, let me see, slideshow. Yeah, from the beginning. Good. All of you have melanoma, or many of you have melanoma, or have a history of melanoma, and it used to be that this was a very rare disease, and it is becoming more common, and I'll sort of touch on that issue. And it is, people are becoming more aware of it for one reason or another. Bob Marley, as you know, had melanoma. There are a group of people here who are quite famous. Our old man McCain, the keyboard player for Bruce Springsteen, Maureen Reagan. And I don't want to leave you with the notion that this guy did have melanoma, but that's a raging controversy about what that is. It shows up. It shows up in a number of pictures and has fueled the debate about what is that thing. I am going to be discussing a couple of controversies, and the key thing that I will be talking about is this whole notion of the sentinel node. That is quite controversial, but I want to weave in the sort of tapestry of what I talk about, which will be very simplistic, and I apologize if it's oversimplistic for people, but I'm used to speaking to medical students, and so that's another reason for my being nervous today, is that you folks pay attention. The medical students don't. And I will get to that in a little bit. But what we're going to be talking about is the role of sentinel node biopsy. The other controversies involve surgical margins, and then the role of surgery in people who have advanced disease. And I want to do it from the context of what patients ask me or don't ask me. But this is what's going through their mind when they come into the office. The first question that they won't tell me or won't ask me is, but they're all thinking is, am I going to die? And I want to point out that I think that there is a lot of reason for hope in this disease, and the vast majority of patients are not going to die. They're going to do well. The next question is, why did I get this? As many of you know, melanoma can occur in the vagina and the rectum, and that's the first question that women ask me when they have a vaginal melanoma. They said, well, I understand this is just caused by sunbathing. And I say, yeah. Shouldn't have done that. What am I going to do about it? We are going to talk about surgery. The next question is, why such a big cut? After surgery, the question that everyone asks, everyone wants to know, is did you get it all? And that segues into what John is going to talk about and some of the issues on genetics. And then, do I need any more treatment? I have here a picture from the Vatican, which is of the Roman deity Janus, who's a two-faced god. It is why it is after him that January is named, because obviously you're looking forward and looking backwards. And I think in melanoma we have every reason to look forward with hope. This is a disease that I have been intrigued with since the early 80s, when I spent time at the NIH. I'm involved in research in this disease, and I'm very engaged in this disease. I think the disease is two-faced. On the one hand, it can be very aggressive. But on the other hand, it's very unpredictable. Patients can do extremely well. And so it allows us to advance with hope and advance aggressively in patients that have this disease and really be able to offer out to patients the hope and notion that treatment with curative intent is a very realistic and potentially plausible thing to do. So I would say that hope is the one message that I want to leave with this. And am I going to die? Well, no, most patients don't. Most patients do fine. This particular bust is in the Vatican. I toured the Vatican with my son as a graduation gift. My son wanted to go to Italy, so we went through the Vatican, and I took pictures of everything. And then finally, after me taking a picture of a block of marble, he said, "Dad, stop that right now. You don't even know what that is." So I thought, well, isn't that great? It's payback time. So am I going to die? Well, this, the important part of melanoma management is putting patients in groups where we can say what they're going to do based on our knowledge of the natural history of the disease. And the vast majority of patients end up in early stage. And it is important for patients to know what stage they're in, simply to have a sense of what group they're in, what options are available, what should be done. Part of my job as a surgeon is to further define the stage the patients are in. And I will be talking about that in the context of doing the sentinel node procedure. Part of John's job, and all of us that do research in this disease, is to make these statistics much better for patients. And again, within the paradigm of melanoma being two-faced, there are incredible advances almost on a daily basis. Your previous speaker talked about the Plexicon product. I mean, we have seen early responses with this drug that are nothing like what I've seen in years. So there's a lot of reason for a lot of hope. But the vast majority of patients end up in stage 1 or stage 2. Shouldn't have done that. And so they generally do well. And so there's a very good reason to be hopeful and expect the patients will do well. Why did I get this? Well, that's another question that people ask. One of the interesting things is that the incidence of melanoma is skyrocketing, and nobody seems to know why that is. When back in the 30s, the chances of getting melanoma in this country was about 1 in 1,500. This slide, I think, is outdated. I think the chances of getting melanoma for the general population is now much higher than 1 in 74. When I started here as an attending physician in the, when was it? 90s, late 80s. Melanoma was still a fairly uncommon thing, particularly in Pittsburgh, which is, as I understand, the second cloudiest city in the country. And it looks like we're trying a little bit today, but certainly the last couple of weeks have been testimony to that. So why are we seeing more of it? Well, nobody really knows. It is the fastest growing tumor in incidence right now. It is thought to be an interface between environment and genes, and I think our last speaker very nicely went over some of the fundamental mechanisms of melanoma development and the possibility of a genetic role in melanoma development. But it looks to be, I think, a combination of soft hereditary factors, hard hereditary factors, and probably an environmental role that was alluded to earlier. Now, if you look at places in the world where you see a lot of melanoma, red being high incidence of melanoma, you see an interesting thing. And that's, is anyone from Australia here? No, I'm British, so I can say what I want, I think, about Australia. But this is interesting, and I go through this with the medical students, but does anyone know why that's such a high incidence? Yes? Yes, correct. So what you have here, I mean, Australia is a lot of sunlight, and you have a high incidence of melanoma in Australia, but you don't see that over here, which is where I was born, but that was an anomaly. But sub-Saharan Africa, a lot of sunlight, but you don't see melanoma there. But there's something special about Australia. And in the 1840s, the small colony of Western Australia was in bad economic strait, desperately requiring more labor to survive. So what did they do? They dumped out all the prisons from Britain and put them in Australia. So you had a bunch of people living in Australia that weren't designed or built to be there. And so you ended up seeing a huge amount of melanoma in that country, and that remains a major healthcare problem in Australia because you've got people there that aren't supposed to be there. They're not genetically built to be there. And so, again, still addressing how come I have melanoma, we currently think that it's probably an interplay between genetic components, which our last speaker has gone over beautifully, and impact of the environment, namely sun exposure. And the current thinking seems to be that the recreational sun exposure seems to be a major issue. And there are a number of sociological studies, cohort studies, well-controlled studies that seem to lend credence to that notion. One of the things I didn't know was that animals like to sunbathe too. And I felt sorry for him, so I did order him a pina colada. People have always sunbathed. And this apparently is how they did it in the 30s and 40s. I will take their word for that, but again, there was not, the notion was that was not a huge amount of sun exposure that went on, even though people did like to get sun exposure in a recreational fashion. But now the recreational sun exposure seems to have changed. And I do use this slide for medical school teaching. At this point, the students are mostly asleep. There's about an 80% sleep rate. So I say, okay, in this picture, there are at least 4 topless girls, at which point all the men in the audience wake up at least briefly. But it seems to be that one of the thoughts is that recreational sun exposure has increased. The notion of having a tan is sort of seen as marking the rich social classes, and it's something that's sought after. The Australians have recognized that, and they have gone on a significant public health measure in terms of trying to get people to use sunscreen, avoid excessive sun exposure during certain hours of the day, etc. So why did I get this? It looks like it's a combination of genetic factors, which will certainly be much more relevant to the patient with a rectal melanoma or an anal melanoma, and environmental factors. I see a lot of patients blaming themselves for sunbathing, but I don't think that's the whole reason. For many of the patients and many of the patients in the room, the Celtic background or Germanic background is probably much more relevant than any history of sun exposure. What are you going to do? Well, the approach to primary melanoma remains in 2010 surgical. And the 2 games of surgery, one is to get rid of the primary melanoma, get rid of it, and that is done with what's called a wide excision. The second component of what I do or what I like to do is find out if it has spread. That then gets back to the notion of staging patients. If it is spread, that group of patients in general does a little bit worse or does do worse than the patients who haven't spread. And that stands to reason. That's true for all the other cancers as well. Breast cancer, thyroid cancer, any cancer you want to name with a few exceptions. Actually, thyroid cancer is one of the exceptions, certain types of thyroid cancer. But in general, if the cancer has spread, patients in general do a little bit worse. So there are 2 goals for surgical management. One is to get rid of the primary with a wide excision. The second is to stage the patient to see if it has spread. And one of the most critical staging maneuvers in recent years is this sentinel node biopsy, which I'll describe. Why such a big cut? People come in and they've got a thing that looks like a pimple, and I'm talking to them about taking a 2-centimeter margin, which is a hole, and I usually do it this big, and everyone goes, oh my God, for this pimple, why would you do such a thing? Well, it was recognized in the turn of century that melanomas grow discontinuously. And so here, and this, oh great. This was recognized by this guy Hanley. and published, this is him here, and this was published in the Hunterian Lectures in 1905. And he recognized on a single case, actually, that this notion of discontinuous growth, and you can see it here diagrammatically as by him, where you can see that if you take out just the primary melanoma, that's all well and good, but that's not going to get rid of these little particles which have extended beyond the location of the primary. And in fact, what you're going to need to do is a much bigger excision than what you would guess by simply looking at the primary. So while, yes, this is just a pimple here, you worry about these skip lesions. And I had a patient yesterday refer to these as flea bites, and I think that's probably a good little analogy. I often use the notion of a shotgun pattern. But the idea is that there's discontinuous growth. Hanley originally is credited with suggesting that all of these need to be managed with 5 centimeter margins. Through a variety of clinical trials, which I won't beat to death, we have revised down the actual dimensions that need to be cut. You can see here on this lady who she's a nursing home patient and basically has a melanoma here, which is in a fairly late stage of growth, but you can see that the growth here has been discontinuous. And so you can see here, here's one of these sort of shotgun lesions, if you want, or discontinuous lesions. And here you can see microscopically evidence of a small satellite lesion. The actual primary melanoma is not on this slide. It's way off, way over here somewhere. But what you can see is right here is one of these satellite lesions. So what we want to do surgically is remove not just the primary, but any of these little particles that have fired off. And so what has developed then through a variety of studies are international recommendations. So how big a cut you get depends in some sense in what country you're in. The Australians, ironically, have a much more conservative margins of resection than we do here. We generally go for 2 centimeters in the intermediate grade melanomas, which are right here. WHO stands for World Health Organization. UK is obviously England, Australia, and the Dutch. But these are international recommendations for margins of resection based on the thickness of the primary melanoma. It is interesting to point out, and this is a whole nother lecture, that in nowhere in the world is Mohs technology recommended as a reasonable approach for primary melanoma. And that is one of the controversies, and that is the source of another lecture. But I will just point that out as a parenthetical point. The big concern, obviously, is cosmesis, if you have to do a wide resection, and we like very much not to cheat on the margins. Both of these are very pretty young girls. Both of these patients have had melanomas. This pretty girl had a melanoma down on her lip. Great. And this was resected with the recommended 2 centimeter margins. And what we ended up resecting on her, this is her after her surgery, was the lip that went all the way from here. And the point of this slide is that we can put these people back together so that they look appropriate and pretty again. And so the notion of having a melanoma in your face is not necessarily a disaster. This pretty girl had a melanoma right here. She was widely excised, so basically we ended up taking off a quarter of her cheek. And she does have a complaint here that's valid. Does anyone know what it is? The eye droops a little bit, exactly. So we did take her back and fix the droopy eye in a second operation. You can see here, I think reasonably that that's been fixed. This is her before the surgery, and this is her after she got the corner of the eye fixed. So we're able to, that was something that one of my patients that I saw this week, and she said, you know, you must talk about what you're going to do about the scarring and how you can make people look good again. And we can do that, and that's something that we offer, and that's something that we can do. But we don't like to cheat on the margins because that we think is important, and I've sort of sketched over why we think that is important. Okay, the next task for the surgeon is find out if it's spread. Sentinel node biopsy and then the imaging studies, which are CAT scans, PET scans, which I'm not really going to talk about, but the notion of the imaging studies are really to look inside the patient to see if they have evidence of visceral disease, disease in the lungs, liver, heart, and all of those sort of things, because that then upstages them. It used to be thought that all cancers grew by direct extension, and this is an image from the Halstedian lectures, who believed, Halsted believed that breast cancer extended by direct extension, and he justified doing a much bigger operation as an appropriate operation for women with breast cancer. And if you had breast cancer in Halsted's day, actually Halsted was the person you should see because his results were much better than his peers. Bernie Fisher, who is a Pittsburgh native, challenged that paradigm by suggesting that in fact what you have with early growth of the primary is unfortunately invasion into the lymphatics and early invasion into the bloodstream. And that is the fundamental problem with cancer as I see it, is that you have unfortunately fairly early on in a number of cases dissemination of the disease beyond the confines of the original primary cancer, and that's certainly something that's true for melanoma. So when you plot out who has nodal disease and who has disease elsewhere, it is a function of how thick the primary melanoma is, and most of you are aware of that. So in the thicker melanomas, there is a fairly high incidence of disease everywhere in conjunction with disease in the nodes. But in these intermediate groups, there are a number of patients who, sorry, I keep doing that, that's not on purpose. A number of patients in this group who have disease in the nodes but don't have distant disease. So if you can identify patients that have disease in the nodes, treat their nodes appropriately, it is quite possible in this group that you're going to cure some people that otherwise wouldn't be cured because their extent of disease is nodal but not systemic. So hence comes the notion of doing a sentinel node biopsy. And the purpose of the sentinel node biopsy is to identify patients in whom the cancer has spread to the nodes. It's no more complicated than that, although the implications are much more profound. And this was something that was actually noted in the, as recently as in the 90s, and that lymphatic metastases spread through clearly definable channels, and that you could identify the draining lymph node by using a blue dye, and this lymph node would be the one that most likely would have received tumor cells initially from the tumor down here. The lymphatic anatomy is such that the lymphatics drain certain areas of the skin. It was always assumed that the lymphatic channels actually drain defined patterns that you could look up in a textbook. It turns out that that's not the case. And in fact, lymphatic channels are dynamic. Everyone does their own thing. That was something that was not recognized until the mid-90s. And so many of the early studies on melanoma and melanoma metastases to the lymph nodes are probably flawed by this misunderstanding of functional anatomy. The way we decide now where the lymph node is actually located, the primary lymph node, is by getting a dye test. And many of you poor folks have had this dye test. And I am told that it hurts, and I apologize, but it's necessary. This is a patient who's standing like this, with the arm up. This patient has a melanoma at the back, and they have had the dye test with the injection of the dye here, around their melanoma site, and what you can see is the lymphatic channels lighting up with a radioactive dye and concentrating in a draining lymph node right up here. And many of you who've had this done will realize that the lymphoscintigraphy people put a black dot right where the lymph node is. And they do that to help me find the lymph node. I actually don't need them to put that black dot on, but I don't have the heart to tell them that. So all of you come in with the black dots and you've been dutiful about not showering, and I don't have the heart to tell you I didn't need you not to take a shower, but be that as it may. I know now, based on this, that your lymph node's right there. Yay. So we take you to the operating room, and we use this little gamma probe which is, it detects radioactivity and it makes a noise and it goes off when you are right over the draining lymph node, because the lymph node remains radioactive after the dye test. Then, in addition to the dye that you got yesterday at the lymphoscintigraphy people, we inject a blue dye, a bright blue dye, around the skin where the melanoma occurred. Most of you are not aware of that because that's done in the surgery. Many of you will go home and pee and it's blue and you go, what's up with that? And I probably should tell more people about that because I've had a few frantic calls. But that is the blue dye that's passed through your body and is peed out through your kidneys. But the blue dye helps us identify the draining lymph nodes simply because in addition to the radioactive signal which we can hear, we're then able to see a collection of blue dye around the node that's of interest. We cut that out and you can see here the blue dye in the lymphatic channel, and it's staining the blue lymph node here. That then we can give to the pathologist who looks at this lymph node very, very carefully. And they look at it so carefully that they're able to find 1 or 2 cells that are bad cells. So they are able to tell us then if the patient has cancer in the nodes, yes or no. If they do, then we treat them differently than if they do not. It used to be that the pathologist didn't look very carefully. And I don't say this in a bad way, it simply is a reflection of economics and all of these things. But this lymph node is, even the surgeon can see that there's melanoma in there. That's all this black stuff. But this lymph node, you can see that there's just a tiny speck of melanoma in it. Tiny speck. And there's actually a story behind this, which I can tell at another time. But fine. So does finding a microscopic speck of tumor in a lymph node, does knowing that help us cure people? We think that it does. And this is a big front page article from the Wall Street Journal published in 2006. And this actually was published before the true article came out in the medical journals. But this was the results of a trial which did suggest, and I say suggest because it's not proven, but it is suggested. This suggested that there was a survival advantage for patients having the sentinel node procedure done and having additional treatment based on the results of the sentinel node. Survival advantage meaning that patients either lived longer or lived longer without disease. And that, unfortunately, as cruel as it sounds, that is our mission as cancer doctors, is to keep people around longer and better. It turns out, and I won't go through all the numbers, that this guy looked at what it means to have a positive or a negative sentinel node. And it turns out that if you want to know something about a patient with melanoma, the single most important thing to know is the status of their sentinel node. So if you have a negative sentinel node, you're going to do 32% better than those folks that have a positive node. Now, it doesn't mean the positive node folks are all going to do poorly. That's not the case at all. But it does mean that all things being equal, you'd prefer to have a negative one. John may talk about this notion of hazard ratio. Basically, the higher the hazard ratio, the more valuable the predictor is. And you can see here the sentinel node status has a hazard ratio of 3.41 in terms of predicting disease-free survival. So it used to be that all of these other factors, which patients are very interested in, and so they should be, like tumor thickness and ulceration, these sort of things are also prognostically important, but the most important thing is the status of the sentinel node. And this is true for disease-specific survival here with a very high hazard ratio, meaning a very high predictive value for knowing what the sentinel node is. And this is how we take care of people currently, as many of you know already. You have an early stage melanoma. We recommend the big cut that I just defended. And you get the sentinel node done. The sentinel node, as I tell patients, is positive or negative. If it is negative, we're done with surgery, yay. And in most cases, we're done with treatment, yay. But if it's positive, then that shunts you down onto a more risky prognostic group that we alluded to earlier. And we do recommend additional surgery. And the additional surgery is to go back and remove all of the other nodes. because 20% of the time there's more cancer in there. And we also recommend that we send you to Dr. Kirkwood's group to talk about additional treatment that may be valuable in terms of extending survival. And that is the interferon therapy that many of you know well. What about surgically treating patients that have, and this is not, I don't know if she's here, but this is one of my favorite patients. We saw her initially, and it was felt that her disease was too far gone for surgical treatment. And you can see here extensive disease down here, extensive disease here. And we went, there's my x-ray. We treated her with surgery. She declined any additional treatment. And again, getting back to the notion of hope, her operation was 10 years ago, and she's alive and well today, doing great. I have offered her, I have offered her correction of that little web in her neck, which she has politely and I believe appropriately said right here. She has politely and appropriately said, thanks, but no thanks, I've seen enough of you. And she has better things to do. And she is, the other reason I'm in this game is because the melanoma patients as a group are a great bunch of patients, and it's an absolute pleasure to take care of them. Okay, I did promise an x-ray of Homer Simpson, and this is advice for all the Olympic folks, and I'm glad that most of them are, like you, not going to take his advice.